So the webinar is live.
Yeah, okay. So thank you very much. On behalf of Pfizer, I welcome all the esteemed faculties for this, interactive, insightful discussion on this evening. So I welcome all the esteemed faculties, Dr. Sushant Mittal, Associate Director for Medical Oncology from Fortis Shalimar Bagh, Dr. Randeep Singh, Director Medical Oncology from Narayana, Dr. Tara Chand, Senior Consultant from BMCHRC Jaipur, Dr. Devendra Paul from Senior Consultant from Ludhiana. So I welcome all the esteemed faculties for this interactive and insightful discussion on Lorla. So over to you, sir, Dr. Sushant. You can carry from here for interactive discussion, sir.
Thank you, Pfizer, for giving us this opportunity. Good evening, Dr. Tarachan. Good evening, Dr. Devinder. And I'll just share my slides. So are my slides visible?
Yes, sir. It's visible.
And they are moving also.
Yeah.
Okay.
Can someone confirm from faculties, and I hope it is visible to everyone?
Yes, visible.
Okay.
Thank you, sir.
Thank you. So it's not a moderating kind of a session. It's a kind of a round table meeting which will happen we have another 90 minutes to discuss the management of ALK rearranged mNSCLC and the first line therapy, what all options we have and how do we go about it. So the objectives would be to discuss about the lung cancer overview, the incidence, the current treatment options, the need for new drugs, testing for CNS disease, how do we manage CNS disease, treatment sequencing, Lorlatinib, it's a new drug, design and mechanism of action, the CROWN study, and the updated CROWN data, and of course the side effect management of these therapeutic options what we have. So lung cancer, it's this slide has been shown in many of the webinars and CMEs, and we know that the lung cancer is one of the most common cancers across the world after breast cancer. And the incidence in India is that according to the Globocon 2020, it's the fourth most common cancer. And majority of the patients, about 44% of the male patients present with distant mets and 47% of the females present with distant mets, that is stage 4 at the time of presentation. And by 2040, we expect that the number of patients would be rising from 72,000 to about 120,000 per year, and that's the demographic change what we are expecting. And the mortality is also going to increase from 66,000 to 110,000 according to Globocon data. So I would like to ask Dr. Randeep, sir, why do you think the mortality is gonna rise in 2 years? It's gonna be almost double, although we have such good molecules, such good techniques, we have NGS what we are coming up. So do you still think that this prediction would be true in the coming years?
So Shant, whatever said and done, see the incidence is increasing, and still you will definitely agree, we hardly see stage 1, 20% stage 2, another 30% or even 10% stage 2, hardly stage 1. I will say 20% is around, or 20, 25, 30% stage 3, and then 60 to 70% of our practice is stage 4.
Stage 4.
Even if we, if we leave the driver mutation negative lung cancers will have an average expected life expectancy of around 2 to 2.5 years in the best of the scenario.
Mhm.
So I think these are the reasons. Yes,
So-
we are lucky as apart from across the globe. I think we are still lucky to have 50 to 60% of our patients having driver mutation positive lung cancer.
So, Dr. Tarachan, what's your take on this? Do you expect that the mortality is going to increase, the incidence is going to increase, or with the newer science, with the newer technology, it's going to come down?
Yeah, I agree with Randeep. Was the one most important thing is also there that, as you said, that new therapies have come and still the mortality is high because of the inaccessibility of the drugs to the general public or the most of the Indians. Whenever the drug price comes down, and usually because of the assistance programs also, because of these assistance programs, patients are able to take medicine at some extent, or the government is sponsored only. Otherwise, hardly 1% patient could take this medicine. So the most important factor, which I think is the inaccessibility to the drug, is the most important.
So you feel if the drugs are affordable at affordable price, then in near future we might see decrease in mortality?
Yeah, maybe because we know that the newer drugs are coming and improving the survivals also. So if these are available to the common man, then it will improve the survival of the cohort.
Got it. Dr. Devinder Paul?
Yes, Dr. Shriram, good evening.
Good evening. Good evening.
Although the 5-year survival overall globally has reached up to 25% in CA lung, but still we have a long way to go. And as Dr. Tarachan and Randeep sir has told, that more and more drugs are coming, but the accessibility part is a big question in our part of the world. So but the picture is looking good. Over the next 5 to 10 years, maybe the accessibility factor will not be that much of a issue, and then we'll see the gains.
So probably what we can conclude that definitely the incidence is going to rise because there is so much of smoking, there's so much of pollution and so much of pesticide, whatever reasons may be, the incidence is rising. But never and if the mortality is also going to rise because the incidence is rising. But if these immunotherapeutic drugs, if these targeted agents are in affordable range, and we have about 40% of the patients who have these driver mutations or who are having PDL1 positive disease, they will have a longer survival, will have longer OS. So definitely the chances that the mortality is gonna go down, but it's gonna we'll get to know with time only what the predictions would be, as the Globocon is saying. So we have different thoughts on this. And now coming to this, one of the second most common incidents is ALK mutation. So I'll start with Dr. Devinder. In your clinical practice, I am sure all of us are getting ALK mutated tested. None of us are there who is not getting this test in any of the lung cancer, whether it's squamous or adeno. So if we are getting tested, what's the incidence in your clinic practice, Dr. Devinder, patient being ALK positive?
Devinder, you are mute. You are on mute mode.
I am not able to see him also.
I think we lost him.
Yeah. So Dr. Tarachan, I'll ask you. So in your practice in Jaipur, how often do you see ALK mutant positive patient?
Truly speaking, I think it is said that it is 4%, I think, as per the literature, but in last 4 years, I have seen hardly 3 or 4 patients of ALK positive lung cancer.
So one per year, you might say that one per year in last 4 years.
Yes, that is the good average. You are a good calculator. That is.
Okay. So, Randeep sir has been the eldest one amongst us. I won't say the oldest one, the eldest ones amongst us practicing. So, sir, what's your take? How often do you see ALK positive patients?
I think it will be less than 5%. I agree with Dr. Tarachand. It will be somewhere around 3 to 4%. And I don't know why there is we don't have 7 to 8%. Even the major institutes, referral institutes like TMH and RGCI, they do report a higher incidence. But it is, I mean, most of us are using an immunohistochemistry based test, and IHC has been, I mean, now very well standardized, and most of us have the Ventana platform in our institutes.
Yeah.
It is not that we are sending outside, but still, even in spite of NGS being in vogue, we still send ALK IHC because that is done along with PDL1.
PDL1.
That then generally we order a once it is adeno, or at least PDL1 and ALK goes together, and then the sample goes for NGS. I think most of us must be following the same practice.
Yeah.
Even after NGS also, I have seen very less. Like with the EGFR, when we shifted from PCR to NGS, there was definitely another 3-4% rise, if you agree, in the detection. But that much has not seen. I mean, ALK IHC negative and on NGS showing an ALK rearrangement or fusion is bit. I mean, the chances of it have been very rare. One of the anecdotal cases in my practice.
True. So, Dr. Paul, I'll rephrase the question for you. When was the last time you prescribed ALK inhibitor for the lung cancer patient? When was the new patient, not the follow-up patient, newer patient?
It was around 2 months back. I started her on Lorlatinib. So yeah, so in my practice also, it's just 2 or 3% of all the patients. We don't get that much of a.
That much. Yeah, that's I totally agree that 8% what we are showing in this pie diagram, even in best of the institute in Indian data, we are not getting. So probably there might be some ethnic difference maybe between the Asian and the Chinese population and the Japanese population, as we had for the in the ALX trial, we had majority of them were Asian population, and we had very good results with ALX and JLX. But then also the Indian population, we really don't have the data, and for such a high data, 8% being positive. So approximately 5% of the NSCLC cases have ALK rearrangement, 5 to 7%, and there are various different variants of ALK, and the EML4 ALK and non-EML4 fusions are there. And as shown in this diagram, we have various permutations and combinations which are available. And ALK and EGFR mutations are mutually exclusive. And if Randeep sir would agree that when we were in TMH, so if we used to do EGFR, we never used to send ALK because they were mutually exclusive. If EGFR was negative, then ALK used to be sent. It was sequentially, not parallelly. But now the scenario has changed. And this is an inversion type of a gene rearrangement that occurs when a chromosome is broken in 2 places, resulting a piece of DNA is reversed and reinserted into the chromosome. That's why we call it a rearrangement.
But so, Sushant, have we, I mean, whatever co-mutations we have, I think all of us can comment. I can't recall in last 5 years, either in the, I mean, a peer group discussion or in my practice, that I have seen a co-mutation without an NGS report. I mean, whenever I have seen an ALK and EGFR co-mutation, I have 2 patients in my practice, but those have been on NGS. I have never seen someone who's been EGFR PCR positive as well as ALK IHC positive.
IHC positive. That's true. I totally agree. That's true. That's
because
true.
this is always a minor clone, and that because of the sensitivity, we have been detecting these.
We have been able to pick it up. Yes, sir. Yes, sir. So the incidence we have seen, what is the preferred testing platform at your center? Randeep, sir?
I do IHC, and then the sample goes for NGS. Once it is PDL1 IHC positive, PDL1 and ALK has been done, and then the sample goes for next generation sequencing.
Next generation. Dr. Tarachan?
Sending NGS panel or with the Pfizer coupon, I'm sending the 90 panel or complete NGS if the patient is affording for the lung cancer.
Okay, so you send them parallelly. All the samples you send them.
Yeah, we usually patient comes as a symptomatic, and we start chemotherapy on the day 1. Usually in the case, and the for the next cycle it comes after 21 days. So till then the reports is easily available.
Now the question is, now as I was discussing, we have various permutations, combinations. So does the ALK variant translocation have an impact on the outcomes or treatment selection? Dr. Devinder?
So not that much for a treatment selection, but yeah, then it gives us more information regarding the resistance pattern, the how the patient will fare on the thing. But if we have ALK rearrangement on either on IHC or on the hotspot panel or NGS, the treatment part doesn't change much of a thing. The treatment paradigm remains the same. It's just the resistance and the other thing which matters.
Dr. Randeep, sir.
So we know there are the variant 3, I mean V3, which is also called popularly, has much more rapid chances of progression on routine ALK inhibitors or first generation ALK inhibitor. There is some data to suggest that Lorlatinib may be better as the third generation of ALK inhibitors for V3 variant. V3 variant develop resistance very fast to first generation ALK inhibitors, and the prognosis is bad and they rapidly progress. V1, V2, there is no difference.
Okay, sir. But it doesn't hamper the treatment. The prognosis might be different.
And there may be a slightly, I mean, that may be one of the reasons, apart from the others we discussed, for putting a patient on a later generation of ALK inhibitors, a third generation ALK inhibitor.
So now, since we have the about 3 to 4% of patients who are ALK positive in Indian scenario, and so these patients are usually young, non-smokers or light smokers, and since they are young, definitely there is a high expectations by the family and by the patient himself to live longer, to give the best of the treatment. Usually when we used to see in AIMS or TMH, they were elderly, fragile patients who were chronic smokers, maybe 70 years old. So the lack of bed availability, lack of treatment. So we used to send them home, at least in AIMS. But now, since ALK positive patients are young, they are non-smokers, so we have to have, and it's our responsibility as scientists, as doctors, to give them best of the treatment. So that's why there is a need for a very good treatment options in such kind of patients. And definitely in 20 to 40% of the patients do have CNS mets in such kind of category of patient, and this CNS is because it's a sanctuary site and can affect the quality of life of the patient. And then we develop ALK resistance mutations. If we start on first generation, then during the course of treatment they develop resistant mutations, and the first generation drugs may not have good CNS penetration, and the durable control of brain mets in patients with these kind of scenarios is very much required. The durable control is an important word, because even after the brain mets the patient needs to have a good quality of life, and there is a need for additional ALK TKIs that prevent the emergence of resistant subclones in untreated patients. So do you agree with all these 4 points, or do you agree, do you have anything else in your mind that the unmet need in ALK positive is very much required, and all these 4 points cover the unmet needs? Dr. Randeep, sir.
I think it covers most of the time, but most of the points. But yes, as the previous, when you started, what Davinder as well as Tarachand mentioned is very important, is about the affordability, because these drugs are going on for months and months.
Yes.
And the more the patients live longer, more is the financial burden which keeps on piling up. I think that is what is missing here deliberately on this slide. Rest, I think, yes, apart from brain, there is a very good, I mean, the good part is that the newer generation of drugs have an equal control within the brain and outside the brain. And we always do tend to forget that if you follow the concept of oligoprogression, radiating the oligocyte or continuing those, you can actually pull for much more of, as compared to the clinical trials. I mean, there is always a 6 to 8 month difference in the driver mutation lung cancer of what data is posted in the, for example, even in the Crown and others. In your clinical practice, this is the only scenario where you have the patients much more longer than the clinical trial. I mean, if the clinical trial is showing a median PFS of 30 months, then you can have the patient for around 36, 37 months or more on that drug, because you are not bound by the criteria to stop it on oligoprogression, and you are not bound by them stopping on asymptomatic progressions and others. Sushant, you are muted.
Oh, I am sorry, sir. So, Yeah. So another unmet need, what you have correctly pointed out, is the financial affordability for the patient, so that we can decrease the mortality, as we had discussed in the first set of our discussion. The fifth point of unmet need would be affordability. Dr. Tarachan, anything else you would like to add?
Sushant, one more point is about I mean the experience and the skill to manage the toxicities.
Yeah, definitely, sir. Yes, yes. I think as the drug becomes more affordable, more and more patients will be given, more and more doctors would be able to have a more experience to handle these toxicity. Yeah. Dr. Tarachan, you would like to add any other point in the
Nothing much was, yes, just I think in this case, age is just a number only, because out of 3-4 patients, 2 are 70 plus of mine only, and one is 35 around, and one is 60 plus, I think. So I think age is number. Yes, smoking, yes, is correlating very well. That the patients who are heavy smokers are rarely found to have a driver mutation positive lung cancer.
Okay. Dr. Paul? Dr. Devinder? Have we lost him again? Yeah, I think he'll rejoin. Okay, fine. Okay. So now testing for the CNS disease. Dr. Tarachan, how frequently do you test specifically for the brain disease? Yes, I agree, you would be doing PET scan. If the PET scan is normal, do you go ahead with MRI? How do you go about it?
Dr. Sushant, was that actually I'm not doing frequently PET if the patient is already metastatic at CT chest by either bilateral lung nodules or not. And if the patient is coming non-metastatic on CT chest, usually come with the only CT chest they feed these people without any abdomen, the CT scan. So in that case, I'm doing the PET scan. But yes, MRI brain to all. I am doing at the baseline as a protocol for me in a metastatic cases.
Okay, so you mean to say if the patient has CECD chest abdo, then you are not doing PET, you're doing directly MRI?
Yes, if the patient is metastatic on CT chest abdo. And but yes, MRI brain I am doing as a protocol to all the patient stage 3 onwards.
Whether symptomatic, whether asymptomatic, irrespective,
yes.
MRI brain with contrast.
Yes.
Okay. Randeep sir?
Actually, I am doing only for a driver mutation positive lung cancer. Yes, the guidelines do recommend to do even in a driver mutation negative. I am aware, and most of the PET scanners do cover the brain. But at least for a driver mutation positive, I would like to have a MRI baseline. But I mean, as we discussed, if someone is actually going on Lorlatinib and the efficacy is so well, is there any point in digging out the brain metastasis when we have to treat? I mean, this is a point of discussion when we have to suppose someone who's really affordable and you have decided that an ALK positive lung cancer is presenting to you and some of the MRI is missing. There will be such a good efficacy. Will you still like to do an MRI?
But anyways, you will get the report after 3 weeks. Till that time, would you like to complete the baseline workup and get the MRI or done or no?
Yes, I would like to do if I'm suspecting a driver mutation positive specifically, and I'm not against if in a driver mutation negative also someone wants to do an MRI at baseline.
Okay. Dr. Devinder has joined us back, sir. Sir, should I repeat the question? You could hear the question.
I know the question. I agree with if the patient is not affordable for a second line or third line ALK inhibitor, and if the patient doesn't have any CNS symptoms, then there is no point going for MRI. But if the patient is affordable for third line alectinib, and then there is no point in going MRI if the patient is not symptomatic, because these drugs have both alectinib and lorlatinib have so much of efficacy in brain. So in asymptomatic CNS disease, it's not going to make much of a difference. But if a patient hasn't made up mind whether he go for second or third generation or first generation, and doing a CNS examination with MR in that patient and getting us medicine that, then we can tell the patient that the survival benefit with second or third generation is more, and then we can go for the third line or second line.
Only Sushant, you are again muted. Sorry.
Sorry. So in this pyramid, The blue topmost is NCCN, which says that MRI should be done. Probably in insurance-based treatment countries like US and UK, ESMO and ESMO, they do it. In the dark blue, the third is the screening for brain mets is preferable, and the green one is the resource constrained setting such as India, in which case to case on scenario basis we decide to do MRI brain is required or no. And as well told by a few of the panelists that if the patient has driver mutations positive, then yes, we would like to do it because we need to know essentially site if the brain mets is present at the baseline or no. However, in non-driver mutation, probably we may be happy just enough with the PET scan report if it's not showing any brain lesion and the patient is asymptomatic. So yes,
Only one point, Sushant. If you have, even if the patient is affordable for alectinib and lorlatinib, and you have 3 brain metastases asymptomatic that can be targeted with SRS, then in today's era, would you proceed with SRS or you would still like to do an ALK inhibitor? Asymptomatic brain.
That question is there. Managing the CNS. Yes. So now the MRI is a treatment of investigation of choice. We would all agree. CT is already PET CT we are already doing, but MRI would be the drug of investigation of choice. Managing, yes, what Dr. Randeep was saying, sir. So if the patient has asymptomatic brain mets, 3 lesions which are amenable or accessible by SRS, how would we go ahead? So we'll ask with Dr. Tarachan, how would you do, sir? Patient is asymptomatic, ALK positive, 3 brain mets, accessible to SRS. You have in DMG, your radiation oncology colleague says I can hit them with SRS. After 10 days, I'll give back the patient to you. So how would you go ahead with it? Patient is affordable for any of the drug and you are muted.
Patient is asymptomatic, then we can go with the TK in the small size lesion. If the lesion size is bigger or the critical, like the critical points, then I will go with the SRS.
So critical would be cerebellar lesions or causing
like a cerebellar lesion or close to the like just a Broca's area and other metal cerebellar. Then I will go for. Otherwise, no.
Okay, Dr. Devinder, would you agree? Would you do the same in your clinical practice?
The patient.
I think we lost him again. Randeep sir, please, how would you go ahead, sir?
So I would like to reserve the radiation if the patient is not symptomatic. There are no pressure effects. There is no hydrocephalus. The mass is not very big. Usually I have seen, especially in ALK positive lung cancers, they generally have small multiple metastases. I would like to start them on an ALK inhibitor, preferably if they can afford alectinib and lorlatinib, either of them. For lorlatinib, slightly better over alectinib for CNS control. I would reserve radiotherapy as a local therapy, SRS or whole brain, for a later line of treatment, whenever they progresses in the brain, in spite of being on a drug. Now, if they're not able to afford lorlatinib and alectinib, then the threshold to give SRS or whole brain RT will be slightly higher. It will be actually very high. So that the brain control, for example, someone who is going on crizotinib and has multiple brain metastases, I would like to give, or 4 or 5 metastases, I would like to do SRS and then start them on crizotinib, because crizotinib has a very good control outside the brain, but within the brain, it is quite inferior to alectinib and lorlatinib both.
So yes, in my practice also, usually patients they have inherent resistance for taking the radiation. We all are practicing in North India, so they say कि भाई shock नहीं लगवाना, doctor साहब shock नहीं लगवाना, बिजली नहीं लगवानी, shock नहीं लगवाना. So there is definitely.
I wish I shall have a support group and you shall merge your patient with mine so that they counsel my patients also.
So I tell them, yes, definitely if we are able to take 3rd generation ALK inhibitors, yes, I will be able to give you a good quality. And I have seen patients. My patient had a lot of ataxia. He was not able to even walk from the door to the chair. He was swaying around. I told doctor, please take radiation. He said, no, I will not take. मेरे को brain भेजा fry नहीं कराना. आप दवाई लिख दो. So I gave him lorlatinib, and after about 2 months, he came back to me and he was absolutely fine. I was so happy to see his scan that the lesion had disappeared completely. And that's one of the patients in my practical experience who gave me the confidence. Yes, lorlatinib has very good CNS penetration. It gives good result. And from there onwards, I've developed this confidence that if the patient is asymptomatic and able to afford the third generation drug, then yes, we can avoid radiation. But yes, the threshold decreases if he's on the first generation or second generation. So Dr. Devinder, welcome back once again. So how would you like to treat
Yes, I know
asymptomatic
the question.
brain
I
mets?
know the question. Sorry, there is some connection issue.
Yeah.
I totally agree with you. If the patient is not is asymptomatic for the brain lesions, even if it's a 2 or 3 lesions, I go if the patient is affordable for lorlatinib or alectinib. I usually prefer not to give radiotherapy. And initially, I had few patients in whom I have given radiotherapy, but the long-term radiotherapy side effects are also there. And I have one patient who was on crizotinib for 2.5 years now with brain mets progression, and now he's doing fine for the last 2.5 years without any brain radiation. So it gives a lot of confidence with these drugs that you can spare the radiotherapy part. Only if the patient is symptomatic for the CNS lesions or it's some pivotal part of the brain, we can give radiation or the SRS.
So thank you.
I
Thank
think
you.
what Sushant said, I will add that even a minimally symptomatic patient also, if they are affordable, we have seen in our practice that we may tend to avoid radiotherapy or rather reserve radiotherapy because we are sure that they will progress someday in the brain. And if someone is progressing in the brain and I have started them on lorlatinib or alectinib and suppose 3 years down the lane they progress, I don't have any good the CNS efficacy drug, and I would be happy giving them at that time SRS or WBRT and then continue lorlatinib for another couple of months. And this data will never come from the clinical trials.
Yes,
They
sir.
will never allow these things in a trial to happen. But in practice, we know we have to treat in this way.
Definitely. So now when the patient is in your OPD with all the NGS report and he is sitting in front of you, so how do you counsel? How do you go about the ALK rearrangement positive patient NSCLC? Dr. Tarachan, how do you counsel the patient? Do you open NCCN guidelines? Do you open the ESMO guidelines, or you just how do you go about it talking to the patient and the relatives?
For ALK first line.
ALK first line, yes. Treatment naive patient.
Yeah, usually, actually, you can say open the NCCN guideline, or you can say the conferences you people teach us in the conferences that which is the best, and also from the company we see the data, whatever that comes. So as per the data, we usually counsel the patient that these drugs are available, and if the patient is affordable, then I go for the hit hard first.
रणदीप सर, आई नो आप तो अपना मोबाइल साइड में रख देते हो आधे घंटे के लिए साइलेंट पे पेशेंट को काउंसिल करने के लिए. So how do you counsel, sir? How do you go about it?
So actually, the thing is that it depends upon their affordability. See, if someone who can really afford, I think we all will agree in today's era, if someone who can really afford, we will not be starting them on crizotinib. Among alectinib and lorlatinib, if I weigh the pros and cons, I will weigh alectinib better than lorlatinib in tolerability. In my practice and in my experience, alectinib is slightly better drug to tolerate, but then it all depends that lorlatinib is a newer drug. We are not yet that comfortable. We have more patients on alectinib as compared to lorlatinib. But if we talk about efficacy wise, there have been the hazard ratios of lorlatinib trial or the Crown trial is much better than ALK's hazard ratio of 0.21. We have seen it only in Adora as well, and then followed by that in Crown, and that has been holding till 3 years. Having a hazard ratio of 0.2, 0.3, we all cherish as a medical oncologist to see, especially in a metastatic or a stage 4 cancer. That is, the lorlatinib is a definitely much more efficacious drug. If someone has a CNS metastasis, I would definitely edge to give lorlatinib over alectinib. Crizotinib and serotinib are there definitely. If someone doesn't have a brain metastasis and they have only outside the CNS disease and they have affordability issues over long term, then I think I would start them on a serotinib and not crizotinib, and serotinib also in a low dose with a fed state with a slight fatty meal, so that we can compromise and have the financial
450 mg.
Yes.
Dr. Paul?
Yes, sir. So I agree with Randeep sir also. So if the patient is affordable right now, we have more patients on alectinib. I have not yet started lorlatinib. because of that the side effect profile is better with alectinib slightly. But it all depends on how we discuss with the patient the needs, the desires, the goals, and of course the financial aspects also. But looking at the difference between the first and third line generation of ALK, we tell them very, very profoundly that the benefit with the alectinib or lorlatinib is profound as compared to the first generation, and it all depends on how we discuss with the patient. But we always prefer that the patient should get the best treatment possible.
So yes, as all of you have said, I also tell the data in the language in which the patient can understand. I tell them that crizotinib was the first drug which was developed. Then the science developed, science progressed. Then ceritinib came. It was second generation. Then we had brigatinib, alectinib, which is again second generation, and then we have third generation drug. And the difference is because not only of the cost, but the beneficial aspects in controlling the disease and benefit in terms of CNS control, and also the side effect profile. Here, my practice is a little different. More of my patients on lorlatinib. Yes, those side effects of cognitive dysfunction and hyperlipidemia are there, but during the course of treatment, after about 3 months, when the PET scan is repeated, those side effects, patients gets acclimatized to it. The weight gain is there, definitely there, but the cholesterolemia is not hampering his quality of life. And when he sees a good report, definitely his cognitive functions also improves. So most of the patients on lorlatinib are doing good, and I have seen that their side effect profile is acclimatized not only in one patient, but whichever patients I have treated, they do get acclimatized to the side effects and start responding very well. So yes, we all counsel in this way. And now the questions comes, how do you sequence the strategies in ALK positive patients with CNS disease? He has CNS disease, so how do you go about it? Dr. Randeep sir.
So Sushant, if I have started them on, which I said, if I have started them on first generation ALK TKI, then especially crizotinib and ceritinib, then I would like to address with radiotherapy, especially if it is symptomatic or there is a high tumor burden within the brain or it is compressing some important structure. Once they progress on this, then they can go on either alectinib or lorlatinib. Lorlatinib again being preferred here because if you see the resistance patterns, very few patients have resistance. The ALK dependent generation mechanisms and ALK dependent mutations are less when the patients are on first and second generation TKI. They are much more when the patients are on lorlatinib or alectinib. That is one thing to be remembered. Now, if someone is on crizotinib and ceritinib, the mutations and the mechanisms will be such that majority of them will respond to lorlatinib. So someone who is progressing on crizotinib, ceritinib, I would be happy to put them on lorlatinib without doing an ALK resistance mechanism. But someone who is progressing on alectinib or lorlatinib, then definitely I would like to do a next generation sequencing, preferably, and then assess the resistance mechanism. That is one difference. Second, which I already told, that if someone is progressing in both EGFR and ALK, we try to exploit as much as possible. I have patient on a ceritinib who is progressing and still asymptomatic, progressing in brain and progressing in outside the brain, not taking radiotherapy, and still it has been a year they have been following. So the progression is very slow, especially when they are on TKI. I would like to exploit them for a minimally, a progression which is asymptomatic, a minimal progression on scans, oligo progression, all of these. After that only I will change.
Dr. Tarachand, for CNS Mets patient. Hello, Dr. Tarachand.
Tarachand, you are muted.
Okay, till the time he's unmuting himself, I think his laptop got hanged. Dr. Devinder, how do you go about it?
Yes, so if the patient is affordable for lorlatinib or elective, there is no role for any CNS radiation upfront if the patient is not symptomatic. But of course, as Randeep sir has said, that if the patient has opted for crizotinib, then of course whole brain radiation has to be given. And I totally agree with him that the patient will progress on crizotinib and to some extent on ceritinib. They have a favorable resistance pattern which will respond most of the times to alectinib. But of course, if the patient is on alectinib and he has progressed, then they have to do the mutation pattern and to see the resistance. And then we are in a bit of a low, in a bit of a disarray what to do next. So so if the patient is on crizotinib, we go ahead with it and we check. We have the second line and third line available. But if the patient is on alectinib, then after that we have to see the resistance pattern and then we have to proceed accordingly.
Dr. Tarachan, are you able to unmute yourself now?
Yes, boss. Yes.
Yeah. I'll ask a different question. The patient is on crizotinib or ceritinib. He has not developed brain mets, and you obviously have shown this graph and you want to use the patient on lorlatinib or alectinib, but he is still not willing. So how, do you for the CNS mets you would like to give the radiation, but if there's a leptomeningeal spread, if the CSF is positive, how do you do about it?
Was first thing that the patient has developed brain mets on the first or second generation TKIs. If the patient is symptomatic, then the radiation will be the first, and the patient is not symptomatic, then I will go with the third generation lorlatinib or alectinib. But for the intracranial, leptomeningeal mets, I have not encountered any case till now. But yes, if it comes, then I will go with the lorlatinib plus maybe intrathecal methotrexate I may use at that time. Or the because otherwise in the EGFR we have seen the osimertinib, but we have no data of the increasing dose of lorlatinib or alectinib in leptomeningeal mets. So I will give some intrathecal drug also along with the lorlatinib.
So with this we'll summarize the second part of our discussion, that in newly diagnosed ALK positive patient, the incidence of brain mets is about 20 to 30%, and international guidelines recommend CNS testing for CNS mets with MRI, and several TKIs have been evaluated with different efficacy, but the best has been for lorlatinib and alectinib, and lorlatinib is the inhibitor indicated for the treatment of adult patient with ALK positive patients. And in the first line setting, when lorlatinib has the potential to manage and prevent the emergence of CNS mets, would be our drug of choice if the patient is able to afford. And better understanding of the prognostication is required to help the patients who would benefit from the therapy and to inform the treatment sequencing algorithms. So if now we come to the third part, so we have so many drugs which have different overall efficacy. If there is, then what is the second line, what is the CNS activity, what is the response rate, what's the progression free survival. So this drug, the lorlatinib, the third generation ALK TKI, has a selective ATP competitive, highly potent third generation ALK TKI with excellent brain penetration in 75%, not only in trials, but in our clinical day-to-day practice, we have seen this. And there is an improved clinical outcomes with overall and intracranial activity in patients with previously untreated mNSCLC. And upfront treatment can completely suppress or at least significantly delay on the on-target resistance, leading to more durable clinical benefit. This last point we will further discuss in the coming slides. But the first 3 points we totally agree, and this is the difference between crizotinib and lorlatinib, that the ALK kinase domain is more effectively inhibited by lorlatinib. And we have various studies in phase 2 studies which have shown that the intracranial activity is very good. Now, this is the pivotal trial phase 3 CROWN study, in which we had stage 3B and 4 ALK positive patients with treatment naive, asymptomatic treatment or untreated CNS patients were permitted, and more than one extracranial measurable target lesions with no prior radiation were randomized into 1:1 category with Lorlatinib 100 mg OD versus Crizotinib 250 mg BD and stratified on the basis of brain mets and ethnicity, Asian versus non-Asian, and the primary endpoint being PFS, which was assessed by the blind community, and secondary endpoints by PFS by investigator, overall response rate, intracranial overall response rate, duration of response, intracranial time to progression, OS, safety and quality of life, and there was no crossover allowed in this trial. So if we see this data, majority of the patients were female. Asian population was well represented. About 44% of the patients were Asian, which is very important in our side of the subcontinent. ALK performance status 1 in what we see in our clinical practice, and light smoker or never smoke, 54% were never smokers. Histological subtypes was adenocarcinoma, adenosquamous in 4% and squamous cell carcinoma in 2%, and that's why we even in squamous cell carcinoma do get the NGS testing done so that we don't miss these little number of patients, whatever they are, and they are not denied the benefit of this drug. Previously used anti-cancer drug was seen in 8 patients, and brain mets were present in 1/4 of the patient had brain mets. So if we see these baseline characteristics, these are almost what we have in our clinical practice on daily based on daily practice. So after 1.5 years, we had the follow-up data. And Randeep sir, what's your take on 18 months PFS data, sir?
I mean, I had already said that a hazard ratio of 0.28 is definitely assuring. These are, I mean, if we have such good PFS with maintained quality of life, I think PFS is an important clinical endpoint because these patients usually live longer. If their overall survival of an ALK positive lung cancer would have been 1 year, I would have been definitely looking at the overall survival also. But these patients live for 3 to 5 years. And if they have a very good progression-free survival on the first line ALK inhibitor, I think it is assuring. And the curves have started separating quite early. You are muted, Sushant.
Dr. Tarachand, previous was the blinded PFS. Now this is the investigator PFS. Again, it is showing that at the end of 1.5 years, there is the PFS is significantly good, and it's a 0.21 is the hazard ratio. So how do you feel about this data?
Sir, I think I would agree with Randeep sir that in this case, when the PFS is good, and I will go, it's a good point because it maintains the quality of life, and I am seeing in the patients also that the response is also very quick. We are seeing the response, symptomatic response within a week, and radiological response within 2 weeks we can observe easily. So patient becomes nearly after 1 month or 2 months become nearly by asymptomatic. So if the PFS is a very good data, because the patient can live like a normal life till the problem.
So yes, and the subgroup analysis, again, as I told you, in this, the one point I would always like to know, although in trials we do not have, is the poor performance status. Performance status 3 patients also who come later to our institute who have in India, we have alternative practices. Patients come back to us after probably 4 months or 6 months of Ayurvedic or homeopathy treatment. And then we find out that they are ALK positive and they have poor performance status. So, Dr. Devinder, would you like to see such kind of data in which poor performance, ECOG performance 2 or 3 patients are also included in the clinical trial so that they make us more confident in day-to-day practice?
Yes, Dr. Sriram, we all will like to have ECOG performance status 2 or 3 in the trial, but in real world, we know those patients will never come in the trial setting. But of course, in our clinical setup, we have seen even ECOG performance status 3 doing profoundly well and showing response within few weeks on Lorlatinib. and even to that extent, to serotonin also. So these drugs are really in clinical practice, as Randeep sir said, the curves are separating very early and they are separating beautifully. And after, I'll say, after around 1.5 to 2 years, the curve is almost like a plateau over there.
Right.
So in a yes, the ECOG performance rate is 2 or 3 patients. They also attain that much of a benefit as other patients I have. And these drugs are really very, very nice to have.
Yeah. So I have my personal experience to share on this. I had a patient who had come to me after taking alternative treatment, and she was a lady and she was admitted in ICU in a small nursing home. So they called me for a reference, and she had all these tests done, but she didn't want to take any of the allopathic treatment. Now I saw that this is the option. You have brain meds, and she's almost on the verge of ventilator. So this is the only drug I can tell you, if you are able to take it, you take it. So I gave the prescription. I came back after probably 3 or 4 months. I got a call back that they wanted to show me, and I was really surprised to see that patient had responded so beautifully. She was out of the ventilator. She was walking and talking, recognizing everyone. So that's the beauty of these drugs. The science has given us so much importance, and yes, as Randeep sir was already saying, that these drugs have shown benefit in clinical practice beyond what we have been shown in the clinical trials. So yes, we would like to see such kind of patients, and I don't know whether the Western population would ever be having such poor performance status patients, but yes, in Indian subcontinents, we should have this data of ECOG performance uh, 3 and 4 patients. Not 4, but yes, 2 and 3 patients should be there. Now, similarly, for the intracranial overall response rate, this Lorlatinib had a 66% response in intracranial, and the median duration response has not been reached. Whereas for Crizotinib, it is 9.4 and significantly higher intracranial response. This we know, and this graph, which is very remarkable and which has given us a good impression of the drug, is that the survival without CNS progression, the line is almost straight. And Dr. Devinder, how would you like to comment on this graph? What's your take on this?
Yes, sir. As I told you, the graph shows that the benefit in the CNS is even more profound as compared to the extracranial sites. So the beauty of these drugs is more profoundly, it's not that that doesn't work in the extracranial side. They also have a very, very good response in the extracranial side as compared to Crizotinib. But CNS is their real forte, where they have their exceptional activity, especially Alectinib and Lorlatinib.
So probably that's the edge they have over other drugs. Dr. Randeep sir.
So actually, that is why I was saying these curves were not seen in the ALX trial. At least this curve was not seen, the one which is present. I mean, we have the same data, but you don't have the Alectinib data showing a flat line for no CNS progression. And this curve and these data are the ones where we sit in the MDT and tell that even radiation does not have a 100% response rate chances. It can also have a 90% response rate. 10% patients can progress on radiation. And also, I think this gives the strength that if someone has a minimally symptomatic patient, I have done in my practice, just started them on steroids so that we buy time for 6-7 days and put them on Alectinib or Lorlatinib.
True, sir. So this overall survival, although the data has not matured, but it is not as impressive as the PFS. The Crizotinib has not reached its median overall survival. The Lorlatinib has not reached. In fact, none of these ALK inhibitors have reached overall survival. So in stage 4, in metastatic setting, when we want an overall survival, but PFS is such a good that we tend to use these drugs, and we accept the drugs on the basis of PFS. So Dr. Tarachan, would you still want to have an overall survival data, or you are convinced with the PFS data to use third line generation?
Yeah, Susanna, as I told earlier, that it is not only the PFS, it is the quality of life which we are getting. Yes, if the OS comes in the favor, then it's a good. Otherwise, PFS is also a very good marker in this case. As you saw also that there is 100% progression free in CNS also. So patient is during the whole PFS is maintaining the quality of life, able to go to his job or work, whatever he or she is doing. and can enjoy the life with his or her family.
Definitely, definitely. I totally agree. So now the safety summary.
Also, Sushant, there are, if you go back on the curve, I feel you don't have that data. If someone is progressing on crizotinib and they are not going on lorlatinib, there will be definitely a difference. And this data is from, I forgot the data set. It is, I think, the SEER data set where it has been shown that if you have a first line ALK inhibitor, patient starting on a first generation ALK inhibitor, and then they're able to go to a second or third generation ALK inhibitor, versus they are not going on a sequential ALK inhibitor, there is a 1.5-year overall survival difference. This is a retrospective analysis, or this is a post-drug analysis of SEER database, where 1.5-year is the difference if someone progresses on crizotinib and then goes with chemo, versus someone progresses on crizo and are able to go on ceritinib and lorlatinib. So that is why I don't think so the overall survival difference may come. And even in Crown trial, the patients, they will have to unblind the trial and patient will go on lorlatinib on crizotinib progression. So it will be very difficult to see the overall survival.
So now the important point, as we were discussing between the ALX and this, is that safety profile. And we had little difference of opinion on that, as few of our speakers were telling that the safety profile. Now, safety profile for lorlatinib, yes, there is definitely hypercholesterolemia is there, hypertriglyceridemia, edema what causes weight gain, and cognitive dysfunction are there. So, so if you have used, what kind of cognitive dysfunction have you come across, Dr. Devinder? Hello, Dr. Devinder, yes.
Sir, actually, I have not yet used lorlatinib in clinical practice, but yes, from the data which we are showing that some sort of dyslipidemia and some sort of peripheral neuropathy, that sort of thing. But I have used alectinib a lot, and it is, as from this data, I can make out that I think alectinib might be a little more safer to use. And but I have not used it, so it's not my. I'm not in.
You have not experienced the lorlatinib, not as of yet. Dr. Tara, have you used lorlatinib?
Yeah, I have used in 2 patients, and yes, patient had hyperlipidemia or lipid deranged lipid profile, but after the starting rosuvastatin at 10 milligram, patients even grade 3 hyperlipidemia become normalized within 4 weeks, 4 to 6 weeks only. So the patients are continuing. And also the same time I did not observe the pedal edema in 2 patients. I have only the 2 patients, both are on lorlatinib, and they are doing well till now without any clinical or cognitive decline.
Okay. Randeep sir, any cognitive dysfunction you observed in your patient?
No, only 2 patients. I am treating one. I've started almost 3 months, and one someone has started. I have encountered it. They are following with me. Both had, as I mean, the exactly same words of what Dr. Tarachand has said in both patients, had triglyceridemia, hypercholesterolemia, very well managed with statins. And usually the cutoffs are quite high to stop lorlatinib. The cutoffs are around 1,000 for cholesterol. I think 500 for cholesterol and 1,000
500 for cholesterol. Yes.
So the cutoffs are quite high. Usually by statins they get controlled. Edema, yes, both of them had. One had definitely edema to stop the drug and restart. The other was having mild edema, as Dr. Tarachand said, and that was easily managed with diuretics and some exercise and others.
So in my patient, yes, he had triglyceridemia, cholesterolemia, and I had counseled them. So rosuvastatin was started, and for edema, he was unable to wear his shoes. That was affecting his quality of life. So I had to start him on diuretics. Aldactone I had started, and he improved with it. But as soon as he used to stop aldactone, the pedal edema used to reoccur. So I had to give him continuously aldactone. And regarding the cognitive dysfunction, the wife of the patient told me that गुमसुम से रहते हैं. He doesn't talk much. Sometimes he keeps staring at some place. So I thought he might be having an absence seizures. So then I realized that it was not an absence seizure. It was probably a cognitive dysfunction what he had. And I had to counsel the patient and the wife that yes, this is expected, but these are not that troublesome as the benefit what we are gaining. So after 3 or 4 months, these side effects reduced. Although the mood disorders were definitely there, relatives tell me that the patient has become more uh, uh, that he becomes aggressive. Sometimes he becomes angry at smaller things. The threshold for his tolerance has reduced. So definitely that is there. The quality of life, the various scales have been used in this scenario. The patients on lorlatinib group had a significantly greater overall improvement from baseline in global quality of index compared to who are on crizotinib. Now, after 18 months, we have a longer follow-up, double of that, 36 months of follow-up data, again, which is showing that this the PFS by the blinded committee, it has median PFS has not still been reached, and at 24 months, at 36 months, the graph is almost 68 to 63%. So, Dr. Devinder, how would you tell us about this data? 36 months, 3 years down the line, patient is lorlatinib and the data is such. How would you counsel the patient? How would this data help you to counsel the patient?
Yes, sir. As I told you earlier, that these drugs with the data showing such a good separation graph and so early separation graph, it gives us that much of confidence to tell the patient, even at 6 months, that is more than 3 years down the line, the response will remain with you, and that's it. So these graphs make us more happy and make the patient also more happy, and so it gives us that much of a more confidence to start these drugs.
Yes. So Randeep sir, brain mets, without brain mets, 3 years data, and the
Of course, it
predicted line is also seen.
What I also realized that I mean, if someone has been on crizotinib and they progress on lorlatinib, even if they have minimal symptoms, I would like to still reserve radiotherapy for them. And I mean, even the patients who are having brain metastasis have also done well. Or even treated brain metastasis also, there were patients in the Crown trial, they have done well actually.
Yeah, true.
And I mean, it's again that 93-94% is actually quite encouraging, Sushant.
Yes, sir. So the next slide, what I'm showing this, the time to intracranial progression is such a good control that even after 3 years, there's 92% of the population do not progress in the brain, which I think is very remarkable because brain is a sanctuary site, as we had discussed previously. The patients on crizotinib are not nowhere to be seen. There were just 37% versus 92 for the intracranial progression. So summary of the intracranial, we have discussed that even after 3 years, the data is very good. The PFS continues to show good response. The intracranial response continues to show good response, and the adverse events have reduced. The permanent discontinuation because of the side effects is just 7.4 versus 9.9 in crizotinib. The safety profile, the dark blue line has reduced after 3 years. The patient has acclimatized to this drug and are able to do well. So the key takeaway are with approximately 18 months of additional follow-up since the interim analysis of phase 3 Crown study, lorlatinib continues to show superior overall and intracranial efficacy compared with crizotinib. PFS by the blinded committee remained longer with lorlatinib than crizotinib. 3-year rate was 63.5 for lorlatinib. Time to IC progression was significantly longer with lorlatinib. And these efficacy benefits with lorlatinib were compared to crizotinib were observed not only in patients with baseline brain mets but also in patients without baseline brain mets. In patients without brain mets, only 1 out of 112 patients exhibited evidence of intracranial progression, suggesting a protective effect against the development of brain mets on lorlatinib. No new safety signals were observed, and these long-term data for Crown trial confirm the efficacy of lorlatinib over crizotinib in treatment-naive ALK-positive patients. So, after this data, does it help you? Does it convince you enough to counsel the patient and try and little push the patient, even if he's little on the financial constraint, try and push the patient for lorlatinib? Dr. Devinder, since you have not used the drug as of now, so I'll ask you, does this data help you to convince yourself, to convince the patient?
the data is both for alectinib as well as for alectinib and for lorlatinib, and to that extent for brigatinib also. The data is so convincing that we have to really persuade the patient to err on the side of third generation. So it all depends on what is your preference, whether you're more confident with alectinib or lorlatinib. So if now that they have launched lorlatinib, of course, I will also use lorlatinib in few patients and see the responses. But for the third generation ALK inhibitors, it's almost the same game. And we have to counsel the patient really well if they can afford this much of treatment. The data of the Crown trial is really impressive, as it with the alectinib trial, and for that extent, the brigatinib trial.
Yeah. Fine. So this is one of the meta-analysis in which lorlatinib in first-line treatment of patient with ALK positive in network meta-analysis was done, and it showed that there was a paired comparison was done, and all these drugs did show that lorlatinib has the hazard ratio which is favoring lorlatinib, is effective in the first line treatment of ALK and SCLC. Although there is no head-to-head trial, but there is a paired comparison which has shown that there is no statistical difference between lorlatinib and other treatment for overall survival. But overall survival is immature for all these studies, and many of these studies have shown crossover is also there. And this another data, another which I came across, it showed that alectinib JLX, which is 300 mg BD, was much more superior for brain control than lorlatinib in this meta-analysis. However, if we see that only Asian population was considered, so probably the ethnicity, the genetic makeup is different. So the conclusion was that in terms of PFS, the results indicate that lorlatinib was the best treatment of choice for such patients. Among lorlatinib, alectinib, brigatinib, crizotinib, lorlatinib has the highest probability to reach the best overall confirmed rates. Intracranial confirmed response rates probability was 44%, and significant improved hazard ratio of 0.57 compared to brigatinib or alectinib 0.59 for ALK inhibitor naive. Reminder that it's a cross trial comparison, and no significant difference was found amongst OS and adverse side effects. So this I think we have discussed. How is the experience for lorlatinib? How do you currently manage the side effects? Given the lorlatinib CNS effects are reversible, we have discussed. In your experience, do you think the effect will impact the quality of life? We have discussed this. So this is another data. Yes, this is the graph, which is this PPT I wanted to show, that in Crown, Alta 1, ALX, JLX, ELISA, and Exalt 3, ensartinib, which is not available as of now, and brigatinib is not approved in India, that all these, the PFS with lorlatinib has not reached compared to other drugs. And the safety effect, definitely the safety, 72% of the patient had grade 3 side effects compared to 26 in JLX and ALX in 45%. But these side effects are manageable and reversible. So the key, I think this we have already discussed. CNS data we have discussed. So side effect profile, yes. So we have discussed this. So lipid lowering agent, yes, rosuvastatin is required, and for this is the drug. If the cholesterol is about 300 or triglycerides are 150 to 300, introduce or modify lipid lowering therapy. Continue the dose at lorlatinib, same dose of lorlatinib. If it is severe is cholesterol more than 400 and triglycerides more than 500, introduce a lipid lowering agent or increase the dosage of ongoing lipid lowering agent or change to a new lipid lowering therapy. Continue the same lorlatinib dose without interruption. And if it is light threatening, then definitely withhold the lorlatinib till hyperlipidemia is moderate or mild before recharging the same dose with maximizing the lipid lowering therapy. And I think all of us are following these guidelines. The side effects in cognitive changes in The functions, mood and speech is there, generally mild in severity, intermittent and improved or resolved upon dose modification. These adverse events are reported to the tune of about 40%, with 12% of the patient experiencing more than one type of CNS effect. Baseline CNS mets were present in about 70% of the patients, and of the patient who had CNS effects. So if the patient does have CNS side effects, just go back to your MRI and see whether the patient has CNS mets or no. And of the total 24 patients who required more than one dose modification as a result of CNS effects, 15% of them experienced resolution. The median time to resolution is about 2 weeks, and recurrence of CNS effects on challenge at the same dose or reduced dose occurs uh, in 6 and the 7 patients. Just about very minimal patients the recurrence happen. So again, the dose modification for CNS side effects, grade 1, which is mild, continue the same dose or re-challenge the same dose or reduce the dose by 1 level, that is by 25 mg. Moderate to severe, withhold till the effects becomes grade 1 and re-challenge at one reduced level by reducing by 25 mg per setting. And if it is grade 4, life-threatening, suicidal tendencies, not eating, just bedridden because of the drug, then it has to be permanently stopped. Best is to instruct the patients and caregivers about these changes so that they are mentally prepared that such kind of things will happen. So now the question is, when the patient progresses, Randeep sir, do you re-biopsy your patients at progression?
If I have, if someone can afford a Foundation One or a Caris type of a standard international platform, I'm okay with a liquid biopsy. Otherwise, I would like to prefer biopsy of the site. Yes, only one difference is that if there is an epithelial mesenchymal transmission, we see less as compared to EGFR. If there is a small cell transformation, or if clinically I suspect a small cell transformation, then I would definitely do a biopsy. If someone is on crizotinib and then I'm putting them on lorlatinib, I may not do the resistance mutation testing. But if someone who is progressing post alectinib and lorlatinib, definitely they will go for a biopsy of the tissue preferably, and then a next generation sequencing with a complete panel of fusions so that we can diagnose the ALK dependent and ALK independent resistance patterns.
So Dr. Tarachan, any difference in opinion, or would you agree?
Yes, I agree with Randeep sir that if the patient is on first line, first or second line ALK inhibitors, then I will not go for the testing, and I may choose at this time point lorlatinib upfront because it is have the maximum sensitivity to the maximum mutations. So, or if the patient is on third line or the resistant on lorlatinib or alectinib, then I will go for the mutation testing or NGS for ALK. For the choosing of the next line.
And Dr. Devinder?
Yes, Dr. Srinath, if the patient has progression to crizotinib or to ceritinib, I usually don't go for a biopsy. I go only for a biopsy if he has an ultra short PFS on these drugs. But if the patient has that much of a PFS around 1.5 to 2 years on these first or second line, I don't go for biopsy second time. But in case there is a progression on alectinib or lorlatinib, for the re-biopsy.
Actually, Sushant, this is the reason. If you see the lorlatinib, whatever mutations we are aware and known, they are all blue here.
Yes.
The G1202R is the commonest, we all know.
One.
That is the reason, that we can, we will be wise enough even if you are not doing. If, theoretically, if you say you can do it even after crizotinib, suppose a patient is not affording for lorlatinib and on crizotinib, I want to start ceritinib, then I may do it. I'm just putting a clinical scenario.
Yes, sir.
If crizotinib patient can't afford it and lorlatinib and alectinib are still out of reach, then in that situation, I may do on crizotinib also and see if by chance he's lucky enough to have a sensitive mutation to ceritinib.
So what you mean to say, probably if the patient on crizotinib has this second mutation C1156Y, so you may be safe enough to use ceritinib in this patient.
Yes, yes, exactly. And then there are very rare mutations. 1 or 2 mutations are such that even if they progress on lorlatinib, they may again respond to crizotinib. I don't
Crizotinib.
remember the name and nomenclature of
Yeah,
those
so
mutations.
this is the data, ALK dependent and ALK. So yes, if and it will happen in the reverse fashion also. If the patient on crizotinib shows that he has G1202R mutation, and we show him this data, then probably we will be able to convince him more. I don't know whether he'll be taking it or not, but from our part, we'll be able to tell him the correct data. Yes, sir, you have this mutation, so serotonin, alectinib, brigatinib will not work, but lorlatinib will work. So if you're able to take it, take it. Otherwise, we'll have to push him for the chemotherapy, because otherwise giving alectinib, brigatinib or serotonin would not help, because he has developed this mutation, which is one of the most common mutations. So as you were saying, sir, initially, that as lorlatinib is used in second line and third line, the PFS decreases by 1.5 months every time the sequence. Suppose in first line you use first generation, then second generation. So by the third generation you use, you must have by 3.3 years or 3.5 times you had lost that benefit of lorlatinib. Similarly, this data showed that as more generation of ALK-TKI are sequenced, more monster ALK resistant mutations appear, which probably lorlatinib may not also be able to take care of. So this is the data. This is the slide which helps us to guide as to how the sequencing can be done for such a patient, and which shows that if we use lorlatinib upfront, for which the PF has not been reached, we don't know what is to be done after the patient has progressed. So probably chemotherapy, radiotherapy, or immunotherapy may be used. But this is the way, in Indian scenario, this is very important as to if we are using crizotinib, then serotinib, then lorlatinib, or serotinib followed by lorlatinib. So these slide is important in Indian scenario, definitely. So the key takeaways are: in treatment naive ALK positive NSCLC compared to crizotinib, the first line lorlatinib results in a longer PFS, higher overall and IC response rate, improved global quality of life. Safety profile is similar to as reported in the previous study. Grade 3 or 4 adverse events are more frequent with lorlatinib than crizotinib. The majority were asymptomatic and readily be manageable. And with the sequential ALK inhibitor treatment, approximately 35% of the patient will develop ALK resistant mutation on lorlatinib with a solvent front, which is ALK G1202R containing compound mutation, which becomes the most common on target resistant mechanism and predominantly refractory to all other known ALK inhibitors. And these results support the use of lorlatinib as an effective line of therapy for patients with advanced ALK positive NSCLC. And with this, I'll just take final comments from my esteemed panel. Dr. Tarachan, your final comment.
I think Dr. Sushant, you have covered all the topics of the ALK related, and I think I am more wiser after your discussion on the ALK positive, and I will be in better position to treat my patients. So I think, and again, the lorlatinib and alectinib has nearby equal efficacy with the different side effect profile, like the diarrhea, and is having alectinib and lorlatinib needs another drug, which is statins, rosuvastatin. But yes, at the same time, the PFS is very good as per the hazard ratio, and that gives the very good quality of life to the patient. So I'm still inclined towards the lorlatinib, because I am not having the experience of alectinib. When the patient came to me for the ALK positive, then I treat the lorlatinib was available, and I started using this.
Dr. Paul.
Yes, Dr. Siddhant, these drugs are really too exciting. They're really very, very too good. And to see a patient with the upfront brain metastasis surviving for 3 years, 4 years, and have an absolute normal quality of life, it gives so much of a satisfaction to both the patient and to the physician also. And this is an ongoing field. We have many more drugs to come, and the horizon is looking very nice both for the patient. And it's just the cost issue which we are facing in our part of the world. And I just hope that with the coming times, the cost issue will not be that much of an issue, and we just want to give them as much as a benefit to the patient as it's possible.
Thank you, Dr. Randeep sir. Your final comment, sir.
I think there are 3 points. One is that if they are affordable for third generation ALK inhibitors, then try to keep your threshold really, really very low for brain RT as much as possible. Try to avoid radiotherapy. Once you have started someone on any ALK inhibitor, try to take maximum advantage by using oligoprogression or using them beyond progression. And third, that if the patient is on crizotinib before starting chemotherapy, I think we shall always take advantage of NGS. Nowadays, the ALK resistance mutations are covered by most of the Indian companies and panel also before starting on chemotherapy.
Thank you. Thank you, sir. Thank you, my esteemed panel, for a very wonderful academic feast. With this, I'll hand back to the organizers, Dinesh Chandra, sir.
Sushant sir, Pratik this side. There is a question for you in the query box that do you follow sequencing of ALK TKIs and the incidence of compounded mutation in the course of treatment if started on first generation? So you are muted.
Okay, I couldn't see the question. The question is, do we, can you repeat the question, please?
Sir, do you follow sequencing of ALK TKIs and the resulted compounded mutation if the patient is started on first generation TKI?
Yes. So yes, we do start first line generation. We have to follow sequential because all of our patients may not be able to afford the third line generation drug. And yes, as we were discussing, the compounded resistance is there, but it is very well taken care by the third generation Lorlatinib, which takes care of these resistant mutations. So yes, we in sequential practice we do try and get the NGS done to find out what resistance the patient has.
And sir, other question is for the treatment naive patients who are affordable, what will be your choice?
My choice would be Lorlatinib. I've used this drug. My confidence on the drug is on the molecule is very good. Although we have other options, but all these options are correct. But as a physician, you gain confidence on a molecule to try and give the best to that patient and to achieve the responses. And you yourself have your own data and confidence as to how the drug will work and what the patients can expect and what you can expect. So my drug of choice would be Lorlatinib in the ALK positive treatment naive patient.
Thank you,
Sir, thank you very much. I think it was a very, very interactive, insightful scientific discussion. It's not only the slides covered, there is a lot of practical aspects covers while treating ALK positive patients. So from the bottom of my heart, I want to thanks for all our esteemed panelists who has spared their valuable time on this evening. So thank you, everyone. Dr. Sushant, you can put a closing remark, then we can conclude this scientific session.
The closing remark is thank you so much. I also learned with these academic small group meetings, we do have discussions and we can dissect the data very well. And thank you so much, everyone, for joining in. And thank you, Pfizer, for giving us this opportunity.
Sir, from Pfizer, we will continue this our long tradition for interactive scientific discussion, and we will continue this kind of meeting to have with all of you, sir. Thank you, everyone, sir.
Thank you. Good night. Good night, everyone.
Good night.
Good night.